Hello and welcome to Tell Ted. This is my show where I broadcast from my world headquarters here at WCTV, based on the campus of Wadsworth High School. And I meet people in the city of Wadsworth that have a connection here, and I invite them to come in and tell Ted. My guest today, Vince Whalen. Vince, welcome in.
Thanks for having me, Ted.
Thanks for stopping by to tell Ted. Vince and his wife Kathy own a business here in town called Wadsworth Family Physical Therapy. How long have you guys been there?
We've been there since 1992.
92. So you've been around a while. And sadly, I know of Vince's practice with his wife because I end up going there as I get older for physical therapy, which is necessary if you need it, but it's not a place you want to hang out. Vince, let's start at the beginning. You and Kathy are not from Wadsworth, correct?
Yes, I grew up in Akron, Ohio, and my wife is from Bridgewater, New Jersey.
You guys met in college, I presume?
Actually in graduate school, yep.
Okay. Where did you go to high school?
I went to Walsh Jesuit.
One of how many siblings you got?
I have 6 other siblings.
Okay.
So I'm the middle child, so tortured.
What did Dad do in Akron?
So actually both of my parents are from Chicago,
Oh.
but my dad worked for Firestone, so in 1968 we all moved out here to Akron because of his job.
So was he already with the rubber company in Akron? I mean in Chicago?
Yeah, he was with Firestone in Chicago.
Okay.
And then they transferred him to
Gotcha.
Akron.
And that was when?
That was 1968, which was
A long time ago.
Akron was a way different city then, so it was a big shock, especially for my mother, who always lived pretty much downtown Chicago, to come to Akron.
Wow.
But she grew to love it.
Where were you? What age were you?
I was 5 years old when we moved here.
So you Akron's been home to you.
Yes.
Yeah.
Yes.
That sounds good. And you went to high school?
Yeah, Walsh
At
Jesuit.
Walsh.
Yeah.
And when you were going through high school, did you play sports?
Yeah, soccer was always my love. I played in grade school and high school, and that's really what got me interested in physical therapy. I ended up coaching at Walsh, and so I started investigating different training things and stuff, and kind of fell in love with all the science of training back then, which was pretty rudimentary back in the 80s.
I got to believe that.
But kind of lit the passion for a physical therapy path.
Did you start coaching right out of high school, or was this after college?
Yeah, back then really no one knew anything about soccer. So I actually started coaching when I was in high school. I coached the grade school at St. Hilary. I had younger siblings that played there. And then when I graduated, Walsh took me on to coach just the freshman team, which I did. And then I ended up transferring to Ohio State, so I had to leave the area and didn't get to coach again there.
So you did your undergraduate at Ohio State?
Yeah.
And then where from Ohio State?
Then went to Columbia for physical therapy.
Let me go back a minute. So when you went to Ohio State, did you already know you were heading into physical therapy?
No. So I didn't know that until really I was a junior. So back then, most all the programs were bachelor's degrees for physical therapy.
That's what
But I was slow to figure out what I wanted to do. So back then, there was like 10 or 11 master's programs. So that's the route I went. That's how I ended up in New York.
So you ended up at Columbia. Now, have you met Kathy yet at this stage of your life?
No, I just met her first day of school.
First day of school of
Columbia. Yep.
And chance meeting, were you guys playing soccer? How'd you guys meet?
We were classmates, and she caught my eye right away, and that was about it.
All right. And did she finish and you finish? You got your master's?
Yeah, we both graduated together.
From Columbia. Mm-hmm. And was there a plan after Columbia for you guys to get married or keep seeing each other? Or?
Yeah, so we stayed in New York, got engaged there, and then so we both worked there for a couple of years. She worked at Columbia Hospital, and I worked up in the Bronx at Albert Einstein.
Wow.
And I worked a little bit downtown in a practice in Midtown, which was kind of cool. It was a sports medicine place. And then we really knew we didn't want to try to raise a family in Manhattan because we'd have to live off rice and beans back then. So we looked around and decided to come back to Akron.
And I'm not sure if that's got any better. I think that's still a pretty expensive place to live.
It's a tough place to make it.
Yeah. And we'll get to this later, but you just mentioned sports medicine. When I think of physical therapy, I think of sports medicine, I think of chiropractors, I think of orthopedics, I think of all kinds of things. We'll see how that all blends in.
Okay.
So you're out of Columbia, you are working a little bit, and when did you decide to bring Kathy home and introduce her to mom and dad.
Oh, yeah, so we did that pretty early after we started dating. And
you got to go to Connecticut to meet mom and dad.
yes, yeah, New Jersey, actually.
New Jersey.
Yeah, yep.
You came out unscarred, so you guys...
Right, I came out on Scar, right, exactly.
Were you married when you moved back to Akron then with Kathy?
Yep.
And where did you start? Did you start a practice in Akron?
Yeah, so our first office was actually in Barberton. Myself and one of my college buddies opened up in Barberton, and Kathy worked for SUMA, which was, I guess, Akron City back then.
I think so. In physical therapy?
Yep.
Okay.
Yep. So
I don't remember Wadsworth having a physical therapy place when I was growing up in the 60s and 70s.
Yeah.
There wasn't one, was there?
No, I think we were the first one besides the hospital.
Outside the hospital of any, Barberton probably had it. Akron did.
Right.
Is there a reason that it wasn't a private practice back then?
I'm not really sure why no one came. I think, the city's grown so much since we opened.
Yeah.
There probably just wasn't that much demand. But Dr. Torok was at Wadsworth Hospital. He was the orthopod and just felt like he needed more help. So through a mutual connection, we ended up meeting him, and that's kind of how he said if we open up out here, he would have patients to send us, and that's kind of how we started.
Okay, so you're in Barberton. You've made this connection with Dr. Torok. Mm-hmm. And did your partner come with you here to open the Wadsworth business?
No, so Kathy and I ended up opening in Wadsworth separately.
Okay.
My partner and I, back then it started becoming way too much having two practices, so we ended up selling that practice. He had also another practice in Hudson, so we kind of went our separate way. Yeah, got really busy.
Was it, how was it handled back then with your, and we'll probably get into this more later too, but when you opened up, were you billing the healthcare insurance companies? Or were people ever self-paying, or how'd they do that?
All along it's pretty much been most patients are insurance. Probably 95% of patients are insurance visits.
And we'll get into more of that in a minute, because you and I have talked about this, questions of you being a specialist and all that kind of stuff. So you came to Wadsworth, that wasn't a physical therapy or even a medical building, was it? Was the building even there?
No, we built the building, actually.
What's the address? Might as well tell everybody that.
145 Smoke Rise Drive. We're over by across from the Walmart.
And right next to the child care.
Yeah, the kinder care.
Kinder care.
Yeah.
Equipment, everything. You had to start from building the building. Who engineered, who architected? Well, we do all of that?
Yeah, we ended up first starting on Boyer Avenue, rented a little like 1,200 square feet office there, and we were there for like a year and a half, and then it exploded really quickly. Back then, really, no one was doing. There's this McKenzie system for the spine, which is kind of getting popular, and we were doing that early. And that was the system Cleveland Clinic used. So all of a sudden, they're sending us all these people because I think we were the fourth people in the state to start using that system. So everything just kind of blew up on us quickly.
And I presume you'll explain what that system is here in a little bit?
Yeah, we could talk about that.
Okay. So you took off there and then started scouting around for property and...
Yeah, one of our patients found the land next to the Lou Perry building, which there's really not much up there, but we're like, whoever owns this building is probably pretty smart, so we figured we'd move next to him. And it turned out it was a good move for us.
Yep. Lou Perry had a connection here in Wadsworth for years. So you open up in Wadsworth. Was it scary? First of all, husband and wife working together usually leads to homicidal thoughts. Yeah. You and Kathy obviously work great together.
Yeah, I think
I've seen it in action.
Yeah, I've always enjoyed working with her. Going through school together. We've just always, that's how our relationship's always been. We've always been together a lot, and thank God for her. I don't know how she puts up with me, but she's very easy to be around for me. Business
decisions, though, are different than your medical decisions. You guys were pretty, I presume, on board with each other in how you're going to treat the patients. Business decisions can be different.
Yes.
Did those get dicey?
Not really. My dad was an executive with Firestone, so growing up, he'd make us read, U.S. News and World Report, analyze the article, tell them the pros and cons. So I was kind of got business beat into me by my father, and Kathy's dad's an accountant, So we both had, I think, a stronger business background than probably most people in healthcare. So we were pretty comfortable working with all that.
And good guidance.
Yeah, we had good guidance.
Sounds like real good guidance.
Yeah.
So you throw open the doors up on Sunrise?
Smoke
Rise.
Rise. Yeah.
And did you advertise? I mean, like dentists and doctors advertise all over billboards and everything these days. How did the word get out?
Yeah, we never really advertised. Just, I think, if you do good work, hopefully the word gets out that way. So it's really been mostly word of mouth. And then, we have talked to physicians over the years and given talks and things to different groups, different hospitals, and all those things kind of help.
All to promote the business or to promote physical
mostly,
therapy in general?
Yeah, they're mostly educational talks that we've done. We've done a lot of talks over the years. We usually do a couple a year, on various issues of physical therapy. So
you're not necessarily going after your brand. You're just promoting.
Yeah, we're just educating
the industry in general.
Right. We've done a lot of that.
We might as well get into some of that because in some of yours and my discussions, you have talked about, I think of physical therapy for what I've been there for.
Right.
I had a hip replacement. I went for physical therapy. I had a knee replacement. I went for physical therapy. But you were talking to me about things about mental stability and balance. Mm-hmm. Can you explain some of that?
Yeah, so let's see, how long has it been? Like about 26 years ago, Cleveland Clinic recruited this physician from Harvard to start their balance program, their vestibular program. Vestibular is kind of the big word for your balance system.
Okay.
And he got a hold of me, and I started working with him, and that grew a whole nother end of our practice. That was back, like I say, about 26 years ago. So I got none of that in school. So every Thursday, a group of us would all meet, and he would kind of teach us, and we did that for about 10 years.
Did he come to you, or did you go to the Cleveland Clinic?
I go up to Cleveland Clinic about 7 in the morning. He's very dedicated. His name's Dr. John Ose.
Wow.
And he's just one of these dynamic people that brought cardiology and the migraine people and all these different specialties together to try to solve some of these complicated patients with dizziness. And he ended up doing a lot of stuff with Botox. So we were one of the sites that did research looking at Botox effectiveness for headaches. We did that about 20 years ago.
Do you do Botox injections at?
We don't, but we, are pretty good at picking up the people that need that. And Botox just been a real gift to the profession of physical therapy because it's allowed us to rehab a lot of people that we wouldn't have been able to do anything for in the past.
And for whatever reason, I have heard of Botox being used in a lot of different ways than I used to think of it back in the day. How does that work in physical therapy?
So basically, if you think of it, a treatment will last about 12 weeks.
A what?
A treatment. So
okay.
if you get a shot of Botox, basically think of it weakening the muscle. So you've seen people with strokes and things who are kind of walking around in these positions. That's because the brain is keeping that muscle tight. So by putting Botox into the muscle, it allows that muscle to relax. And then once the muscle is relaxed, then you're able to work on the functioning of the muscle. And it's really just been amazing watching this Botox grow over the last 25 years and all the different applications it has. And I think we're still just on the cutting edge of Botox. We're using a lot for the neurological cases, but really orthopedics hasn't really embraced it yet. But if you think about someone, with a really stiff knee, maybe after a total knee, that'd be a really good candidate. But it's pretty still limited in scope.
When you say a stroke patient, would that have any bearing on whether they could use it to help them get their speech back?
For speech,
or is that more of a?
Yeah, speech is that's a whole other area outside. So speech therapy, I'm not sure how much they're using that.
Yeah.
But they are, definitely using it in the mouth for jaw people, for example. So I've seen it there. We do a fair amount of patients actually with jaw problems, and sometimes same thing, like the brain can actually keep the muscles in the jaw tight so that people can get the Botox to relax it. And
that's amazing.
Yeah.
So what do you do physically for the physical therapy for the balance at your facility?
So the balance system is complicated. I do have a little thing. Do you want me to pull out a piece of paper here on it?
Sure.
I did bring this with me just in case. So I don't know, can we focus in on that, do you think? Or is that too
This
hard
camera,
to
I
see?
think, is going to be your.
Okay, so The balance system is made up of basically the brain's the masterpiece of the balance system. So all the information comes to the brain. Some of it comes from the neck. A lot of it comes from the ears. Your eyes obviously play a big role in it. And then you have this, in your joints, you have proprioceptors. So proprioceptors basically, I know where my hand is without looking at it.
Okay.
And for example, when you had your knee replaced, that disrupts those proprioceptors. So,
Yes, it did.
So you have to retrain that. So all that information comes into the brain, and that's how we move through space. And any disruption in that system can lead to imbalance.
Okay.
And the more parts of the system that aren't helping, the more trouble you get in. So the ear is obviously, we all know, a big part of the balance system. So over here is the hearing part of the ear, and this over here is the balance system in the ear, which has those tubes. And each one of those tubes does a different job, okay? So one of the areas will help you go up and down, one will help you go forward. They have all sorts of roles. And the cool thing about that is these tubes are connected to your eyes. So when you have a problem in these tubes,
Really?
yes, we actually put goggles on over your eyes and put it up on a big TV. And by looking at your eyes in the dark, because light inhibits how we can look at this, then we can kind of see if there's a problem with one of these tubes. The most common problem is you have these crystals that sit on these hairs here where they belong. So they help you know where you are as long as they're in place here. So the tubes sit on these hairs move, and that's how you kind of know where you are in space.
Really?
But when these crystals break off and go in one of these canals, then that's really what causes true vertigo, where you feel like the world's spinning. And this is really what Dr. O's really trained me up on. There's a lot of different permutations of this problem, but that's called benign positional vertigo, BPPV, which is people, they'll roll, they'll get a big spin, and that's kind of the hallmark of positional vertigo.
And is there anything that causes this, or does it age? Is it trauma?
Age is the biggest risk factor.
Oh boy, another thing to look forward to. Thanks a lot, Vince.
I know.
Thanks.
Age for sure. There's been new research. Low vitamin D is a risk factor.
Okay.
Low estrogen. So those age, trauma, and those things we know about for sure. But basically, if you have a problem with these crystals, we'd roll you around and get the crystals back into these sacs where they belong.
And how effective is your therapy for these? What kind of success rate?
Yeah, I'd say in the high 90s. It's pretty rare. Now, the complicated cases, we have people, think of it like BBs floating through a tube. If these BBs get jammed in, then that's a harder case. That's called cupulothiasis, to use a big word. And then we have to send people home with exercises and maybe vibrating behind the ears to try to break these loose.
We're not talking surgery.
Yeah, early on when I first started working with these guys at Cleveland Clinic, they would try plugging these canals. Yeah. And it just really, they've stopped doing it. It really just never worked very well. But I'd say every 3 months we're learning different techniques, and there's so many different permutations of issues with these crystals. It's pretty fascinating. It's a simple system in a way, but like everything else in the body,
managing it is totally different.
Right.
Especially when it gets out of whack.
Exactly.
To use a technical term.
Yeah.
But that's interesting. And let's go into the my thoughts of when I think of physical therapy and chiropractic therapy and sports medicine in general. There's ice baths, there's heat, there's obviously pharmaceuticals. Are any of those off limits for you? Do you include everything? Does any of that work into your practice?
Yeah, I mean, still, for acute injuries, resting in ice is still the mainstay.
Okay.
And heat, we do use that. Early on physical therapy, it's come so far since I started working. Back in the beginning, a lot of it was, I remember going to class and coming almost disillusioned, like there's such little research on really what you should do. And now the profession's all gone to the doctoral level, and we've really pushed evidence-based treatment, saying, okay, what does the research say is the best thing for this problem? And we've made just huge strides. So, the heat and ice is fine, but it's really not going to give people long-standing benefit for most problems. So,
is there a general rule of thumb? I've gone through my hip and my knee. Evelyn has gone through hers. We always seem to get differing versions of which is better, hot or cold for which things?
Yeah.
What does Vince say to hot or cold for what? When I got a sore knee, I got a bad knee, when do I use what?
So overall, for more acute things that are swollen, something that happened in the last 48 hours, so you probably want to ice and elevate it. More chronic things, arthritic things, most of those like heat, because heat brings blood to the area. So that's the problem. But if you have arthritis and then you overdo it and inflame it, then maybe ice will feel good for for a day or two.
Instead of the heat.
Yeah, but heat brings blood to an area. So like in the shoulder, most shoulders have poor blood supply as we age. The shoulder's not great for the design in terms of blood supply. So at 50% of us have a rotator cuff tear. So putting ice on a shoulder that already doesn't have good blood flow, probably in general is not a great idea.
So you're back to heat.
Back to heat.
To draw the blood in.
Yeah.
Additional blood's always good.
Right.
Pharmaceuticals?
Do
you do much with those? You don't prescribe,
yeah,
do you?
physical therapists don't prescribe any medications.
So
we will talk to our physicians. We work a lot with our physicians. Wadsworth's a very supportive community, and if I pick up the phone and say, hey, what do you think about, this patient is having a lot of pain, maybe they could be a good candidate for Lyrica, their pain's kind of out of control, and it's a very good give and take. It's a great community in terms of support, and everyone really working to try to get these patients better.
And I don't even remember how I found you in the first time I went, but I don't remember having a referral. Do I need a referral to walk into Wadsworth Family Physical Therapy?
No, you don't need a referral. Some insurances do require, that's getting less and less. It's actually kind of going the other way, where the insurance companies are kind of pushing us to see people first and screen them out, so try to not add another practitioner on. So there's some of the insurance companies are kind of pushing that way.
I know in that right before I had my knee replaced, I was having spasms down my sciatica, and I couldn't get rid of it. It was horrible pain, and I thought it was my other hip going bad. And my insurance company actually said, before we're going to approve another surgery, we're going to try physical therapy. And that's when I called and came up to you guys, and we got rid of it. You guys helped me get rid of it before I had my knee replaced, because I don't think they would have done it, because I wouldn't have been able to do my knee rehabilitation without the complete use of all my muscles back there.
Right.
So.
Yeah, I think the research and the studies are really supporting a lot of things physical therapy does. So, a pretty cost-effective method. We don't order any imaging, which, again, we have to work with our healthcare providers. But a lot of patients, if it's non-traumatic, most things don't need imaging in order to determine what needs to get done.
Not so much to determine what needs to get done, but for me, I would think imaging would help you determine, are we making progress or not?
Yeah, imaging is a funny thing, there's not a great correlation, for example, for the spine between what the x-ray shows and what the patient's problem is. And even MRIs, we do those lying down. So it's the same thing, like they're not great. I have a buddy who's a professor at USC, and he's a knee guy.
Okay.
And they do dynamic MRI where the patient's actually squatting and doing movements. And then it's like, wow, you can see why the patient's having a problem. A lot of times on that table, lying down, not moving, the knee doesn't look so bad.
I never thought about imaging while someone is in motion.
Yeah, so we're still imaging,
I've never heard of that. Is that common, or is he breaking ground out there?
Yeah, he's on the cutting edge.
Yeah, wow.
But I'm sure, with technology, someday we're going to be able to do that.
But it makes perfect sense. The shoulder, the knee, the hips
yes,
are all going to look different in motion than they do lying or any kind of still position.
Yeah, it's fascinating to watch how it looks on an image.
And is it now? I break down imaging into two groups: one for bones and the solid surfaces, and then you've got the other like ultrasound and CTs that can see the soft tissues. Mm-hmm. What's he using to image?
He's using a dynamic MRI.
So it's basically an MRI.
Yeah.
That moves fast enough to catch it.
Yeah.
Got to be close to real time.
Yeah, it's pretty crazy.
Wow,
yeah.
I would love to see images of that.
Yeah, actually, he's coming out in September. He's really revolutionized our profession. I'm lucky to have him as a friend, but he does like all the NBA players, and he comes out to Akron. He's coming out again in September.
Yeah.
And does lectures for us. So he's really helped us. He started doing knees when we were in school, and he's done it his whole career.
I would think he'd He's going to be a natural for the pro leagues
Yeah, he does a
of
lot.
any sport.
He does a lot with the professional athletes.
Wow.
Yeah.
And I presume that's not, that's still considered experimental, so it's not covered. So
Yeah,
this is
oh,
all
yeah.
private pay, and I'll bet it's not cheap.
Yeah.
Yeah.
I'm sure not.
Yeah, wow. That's really cool. Where is he? What school?
He's at USC.
USC.
Yeah.
Okay. I learned another thing in this past visit with at your fine facility. There's a difference between good pain and bad pain. I think PJ was working on me that day. I was gauging my recovery from my knee, and it hurt. It hurt to do the exercises that he wanted me to do. But he said that's good pain. When I was there for my sciatica and it hurt, he said stop when it hurts. When you're doing rehab for the knee and the hip, they tell you push harder. No pain, no gain. But then he said, wait a minute, that's bad pain that you're getting there. Stop when you get pain. Can you explain the difference?
Yeah, that's a great point. I think that'll be very interesting to talk about. So, if we're so after surgery, you've had all this trauma, obviously.
Everything, traumatized everything.
Right, so think a normal muscle will slide like this, okay? The fibers glide. You get them cut, and now they become unorganized, and they start trying to form scar tissue. And think of scar tissue basically like this. The tissue can't slide. So on a cell level, what we have to do is break those adhesions, and eventually the collagen will reform into normal muscle.
Okay.
So that is what we have to do to prevent. So if you have scar tissue, we need to break that up and get that tissue to break up and remodel and eventually go back to normal tissue.
So it's growing itself back together, kind of jumbled.
Right.
And you need to almost deconstruct that.
Right. So scar tissue is like the biggest problem in physics. That's why we exist almost. Once we cure that, I'm going to have to go get a real job. But yes, that's
Is it like a tangle in your hair? Is it kind of like...
That's a good analogy. You got to kind of work it out.
Yeah, you just one thing at a time.
And when you're pulling on scar, that's painful.
Yeah.
So you're like, okay, but I'm pulling on scar tissue, so I need to do that in order to get my motion back and get the scar tissue. So that's the good pain. That's the good pain. But if we have a nerve that's pinched, okay, so if this is the nerve and we have, for example, a disc or something hitting it, the harder that nerve is hit, so let's make it a back patient, the harder I hit the nerve in your back, the further down it's going to go in your leg. And if I hit it hard enough, I'm going to start getting weakness to the muscle this feeds. I'm going to get numbness, and I'm going to lose my reflexes.
Okay.
So the harder I pinch a nerve, the more problems. So if I pinch a nerve hard enough, for example, at L4 at the base of your back that feeds your foot, you're going to get a foot drop because the nerve's not able to feed that muscle. So as we're trying to get you better, we want to take pressure off that nerve. So we're looking for this pain to actually get better because it's a nerve thing, not a muscle thing.
So the nerve not only being agitated, but repeatedly agitated is the bad pain that you want to avoid. And how, as a physical therapist, do you, number one, determine that, and then how do you structure, I still need to do some therapy. How do I do that without aggravating that nerve?
So that's we talked a little bit about that McKenzie method, and Rob McKenzie was this therapist who kind of revolutionized back pain back in the 80s. So when I first started practicing, everything was heat, massage, and ultrasound. We didn't really understand that really the muscles weren't really the problem in almost all back pain, for example. There's more, you have to go deeper and look at where the discs are and the bones are. And I brought my spine to make it...
Are we getting into kinesiology?
Yes, definitely.
And did you take a lot of that in school?
Yes, basically physical therapy is
kinesiology is the study of bone, right?
Yeah, and movement, the study of movement. So for the spine, I'm not sure how well this will pick up here, but here's your head up here.
Pelvis.
This guy's a little twisted up. And your tailbone's down here, and you have these nerves coming out, okay? And the disc is obviously in between each one of these vertebrae. This is an old spine, so some of these have fallen out from too much talking. But if the disc goes over and hits the nerve, okay, that's really what's going to cause your leg pain. So when we're young, this disc is still juicy, all right? So it's like toothpaste in a tube, and it can shift around. So if it shifts over, let's say we do too much bending, then from a mechanical standpoint, when you do a lot of bending, that's going to push the disc posteriorly backwards where the nerves are.
Okay.
And basically the McKenzie system is just looking for a movement to get that pressure off of the nerve.
So McKenzie system is a form of physical therapy, a guideline, for instance?
Yeah, it's a system that looks at, okay, so here's our problem. What movement should we do in order to make this better? And that's probably what PJ did with you. So for a lot of people, it's working backwards to push the disc back away from the nerve. For some people, it's twisting, side bending. Depending on where the problem is, then we kind of have an idea, and then we have to test you out, and that's really what the evaluation is. We do different movements and see what makes you
and I'm
better.
And I told PJ that I was not very good at hiding. When you hit that spot, I'm gonna grimace, I'm gonna jump, I'm gonna twitch.
Yeah.
I'm not gonna try to hide from you where it hurt.
Yeah, nerve pain's brutal.
Yeah,
You know, it's
just
brutal.
as anybody knows that's ever had any. Yeah.
And then as we age, then this disc deteriorate, and we start getting more problems with this hole. See how the nerve comes through this hole? Mm-hmm. You start having issues called stenosis, and that's basically the hole, instead of being this big, it gets small, and now the nerve starts getting pinched. And that's a real common problem as we get older, of course. Everything's as bad as we get older.
Yeah, age is not getting a good rap here at this table.
Age is not our friend,
No.
but we know these people have a hard time walking, because walking, that hole's closed more, and they feel better sitting. So then we have to train them to try to bend forward, to stretch this hole out and change how they hold their bodies. So when you're arched up, that closes the hole, okay? That would close this, but when we learn to walk kind of with our stomach in and our backs a little flatter, that gives that space.
And is that is that not a surgical repair as well, or
Sometimes,
is that iffy?
Yeah, sometimes it's definitely, if we can't get it, you know, some people are just too far gone, and then the surgeon will go and open up that hole.
Okay.
Okay, so
that sounds scary.
Yeah, you know, spine surgery 20 years ago, I was, you know, the results were not great, but now it's very rare. The surgeons have really gotten skilled. We're doing way better. Remember I talked about, you know, in the beginning we did these MRIs, like, oh, look at this herniated disc, we'll go fix them, we'll fix this. And then we started doing MRIs on people that didn't have problems. We're like, a lot of people have herniated discs that don't have any pain. So we had to work and figure out, okay, what's really your pain generator? So we've learned to do better exams, and so we're picking our patients better. We know which level to do, and it's very rare the spine surgeries don't do well now.
And we've blamed a lot of this on aging, and I suppose some in trauma as well. Where does that nasty, nasty arthritis kick in? Because that's
That's a tough
almost worse than being old.
Yeah, so just to do one more spot on the spine, you have these joints here are called facet joints.
Okay.
And these can also get really arthritic.
Arthritis is just give us a
deterioration
definition.
of the joint. Yeah, the joints just deteriorate.
So
Yeah.
it's not a buildup of calcium.
Yeah, you're losing your protective your cartilage over the joint.
Okay.
And all of us get some of this as we age. So if this joint gets real arthritic, they're actually the nerves that feed this. The surgeons are getting pretty good at blocking the nerves that feed this joint. And a lot of times people will get, you know, a few years of relief from that instead of going on a big surgery. So
They'll just block the pain.
They'll block the nerve. Yeah.
Does that lead to blocking the nerve? Does that lead to less movement or less ability to move?
No, because usually people function better because the pain is
feel
what's
better.
blocking them.
Okay.
Yeah. So the spine, you know, the human body, it's always a balance. It needs to move. Arthritic joints do way better if they're moving, but if you move them too much or load them too heavy, then they swell. So really the arthritis is trying to strengthen the muscles around it to build strength to support the joint. Make sure you keep your flexibility, and then just watch overloading it. You know, it's like, you know, probably with your knee, you noticed you're losing your space. If you carry real heavy stuff, that's going to really compress that joint, and then you're going to have a problem. So trying to kind of aging well, a lot of it is learning what to give up, I think, you know.
When you were going through school, were you was part of your curriculum to watch or observe surgery in orthopedic situations?
Yeah, so
To see, I mean, if you saw that laying on, you would never see that laying on the table because we got a human body wrapped around it.
right.
And when you open up an area to go work in it, you're only working maybe in a small area this big, and everything looks totally different. If you've ever dissected a frog, what they showed in the
Right.
textbook
Right.
is totally different than what your teacher is asking you to put a pin in.
Right.
How did you guys handle that in class?
Yeah, so we did a lot of cadavers.
Okay.
At Columbia and Ohio State, so you do a lot of anatomy, a lot of cadaver work, and that really, once you see that, it just sticks in your brain. For
bet.
whatever reason, it's.
I bet.
Yeah. So I think and then on your clinicals. So when you're a student, they'll send you off to different places, and I got to sit in on various surgeries, and then you see a total knee, you're like, oh my gosh, no wonder this person is so sore. Especially back then. Now they're getting much better at customizing your replacement. Back then, it's like you had 5 on the shelf, they pick one, stick it in, and so the total knee is the same thing. I mean, they're exponentially better than they were 20 years ago.
I went for a CT scan, I don't know, less than a week before my knee, I had a complete knee. And I asked the technician, I said, who's going to be the next person to see this? Assuming that it was going to be my orthopedic surgeon, Dr. Combs. And she said, the company who makes the robot that's going to do the work.
Yeah.
And I said, what?
Yeah.
And she showed me a little video of this robot, and it's got to be programmed with all of the information about my knee, the length of my leg from my hip to my heel, and they're doing things that I was only in there for a knee replacement. I didn't know we were going through all this.
Yeah.
But it is fascinating, and I'm thankful that we live in an era that we do. I'm just old enough to remember grandparents, mine and others, who died with knee pain, who died with hip pain, because there was no such thing as a replacement back then. So we are very fortunate, and you've been saying right along, the physical therapy from when you went to school to where it is today is light years.
Yeah, really is. Yeah, so I'm always encouraging people, if your knee's is pretty much gone, and you're losing your function, and you want to look at your overall health, putting that thing off for another year or two that you need to get done anyway, I usually encourage people to try to do that a little sooner, because you're not going to be taking as many pain pills. It's going to let you get active, let you enjoy your life, and the surgery is just getting so good. It's the same thing. We rarely have a problem with the total joint replacement now. And you couldn't say that 20 years. Some of those we would torture people.
Oh,
and it's
sure.
it's still tough, but it's nothing like it used to be.
Yep. No, physical therapy used to be considered torture to the patients because it was so brutal. I presume that was because of the lack of knowledge on the replacements back in the day.
Yeah,
they just weren't as sophisticated as they are today.
I remember my first ACL back when I was in New York, and we literally would put him in a cast for 6 weeks. Wow. And I remember, I still can picture this guy. I mean, he was in that private practice that I worked at in New York for I don't know how long. He'd just come in limping. I mean, it was a disaster. Now, the ligament didn't care, which we were all worried about. We forgot we actually want the knee to work,
Yeah.
So the old saying, the operation was a success, but the patient died, you know?
Yeah.
Their ligament looked great, but they couldn't walk.
So when you put together the surgeries and the physical therapy, the goal obviously is the moment, the motion, but I think what you just said a minute ago has a lot of bearing. You got to remember what you're going to give up as you get older, because you are going to give some things up. And then how do you, as a physical therapist, determine if I've got a problem in my neck, if I've got arthritis in my neck, and I'm getting pain down underneath my arm, I think it's my shoulder or I think it's my elbow, and you think it's my neck, and that doesn't make sense to me. What makes you think that when I came in because my shoulder hurts?
Well, number one, we know the anatomy, so we know where nerves refer pain. And then the other thing we'll do is, so we kind of have a hint from telling you tell us where your pain is. We're like, all right, we know, for example, the shoulder joint refers here, the neck refers here and down to your shoulder blade. So, shoulder blade pain is super confusing, but 90% of the time it's from the spine. So we cheat because we already have kind of a guide. Okay, this pain tends to be this, but then we'll also move you around. So that's one of the things the McKenzie system did. So when we think this pain is from your neck, we'll do a lot of neck movements and see if this actually gets better. And if that doesn't change, then we'll look at your shoulder. And, the body is, I've been doing this a long time, and I still get fooled. It's tricky. And, is this pain from the hip or from the back? It's confusing.
And when you're saying you'll try different therapies, they're not necessarily going to work while I'm sitting at your clinic, right?
Right. A big
I
part.
may have to go home and do them and then come back and next week and say, that hurt.
Yeah, we're huge advocates. We spend a lot of our time on the home exercise program. We try, meet people where they live. I have a patient who loves to knit, hates exercise. So we try to keep her, just try to do these few things. Other people want to go to the gym for an hour a week and give me more. So you kind of got to listen to the person, really figure out what their goals are and what they really have time to do. It's a busy world for everybody. So we try to keep it kind of simple. But if the exercise takes their pain away, people find time to do it.
Sure. I guess I determined early on that I wanted my knee to get better. I had two goals. I wanted to ride my bike and I wanted to be able to play golf, which I haven't been able to do for 5 or 6 years because of my knee. The only way that was ever going to happen was the physical therapy. Mm-hmm. And the only one who could control how much I did was me.
Yeah.
Nobody else. You can browbeat me, you can tease me, you can make fun of me. The only one that can do it is me.
Yeah.
And if I've seen people not do the physical therapy, and their lack of success just creates issues down the road for themselves because they can't do what they thought they were going to be able to do.
Yeah.
You got to read the book and you got to find out. You got to do the PT.
Yeah, don't do that total joint if you don't have time to put the work in, because then you aren't going to get the outcome you want.
Exactly.
That's
exactly. Now, before we get too far away from the tissue, talk to me about cupping, because it was suggested to me by either you or PJ when I came in to handle that scar with cupping. What the heck is it?
Yeah, so this, I think this got real popular in the Olympics with the swimmers. I don't know if you remember seeing all those guys with all those red marks on them.
I do not.
Michael Phelps, I think, was the big cupping, the first guy you saw cupping all over.
Okay.
But basically, when that scar tissue, again, is the big enemy. And what happens is, you have your skin, then you have your fascia, you have your muscles. And when you get cut, all that binds together into this again.
It's that crumbled up hair.
So cupping is just real simple. You just kind of, if I had a scar here on my hand, I just push this down, okay? And that's going to pull that tissue apart, okay? So the scar, it's helping the scar turn back into normal tissue and keep it from binding all together. So many people after back surgeries things, no one ever works their scar. And then, the scar tissue is the biggest reason people fail surgery, I would say, by far.
Really?
Yes. So if you don't move that scar around, then you have a good result, but you don't have a great result. So we'll often just say, on Amazon, these are almost nothing. We show people how to use them.
Yeah, I think I bought a set of 4 of them for under $30.
Yeah, so we're like, we can show you how to do this. It takes about 3 minutes, and just kind of work it around your scar. You got to make sure the scar is healed.
You don't put it over the scar, right?
Well, you can eventually.
Okay.
Early on, you don't. You put it around it.
You go around the edges of it?
Yeah, but once that scar is good and healed, you don't want to do this too soon because it can definitely open the scar. So
I would think so.
Yeah.
It's pretty good suction on it.
Yeah, so make sure you check with your surgeon or therapist before you do that.
So once you put that on, you just leave it there, or do you move it, or do you?
So it just depends how raw the scar is. So
how new, how recent?
Yeah. So if it's someone who they had the scar a long time, then we'll move it around. We'll leave it on, maybe a minute, and kind of slide the suction cup around, and try to get that scar to mobilize.
Okay.
And then it's like everything else. If you overdo it, overdoing things, then you swell. So you broke up so much scar tissue. Now you swell so much, you're not going to move it, and that's defeating the purpose. So we want to break up the scar tissue, but not to the point it's so swollen that you can't move it now for a week. So the idea is it's a balancing act between swelling and motion. That's a big battle in physical therapy.
That is. Who knew balance was part of it?
Yeah, so
my dad always said if a little is good, a lot is better. But
yeah, so if you suck yourself for 15 minutes, then it's going to swell up, and then swelling creates problems with scars.
Once you get some of that entanglement ironed out of the scar tissue, will it stay undone, or are there chances it'll go back? Can you keep doing something to keep it back where it belongs?
Being 62 now, I realize that stretching, I think, becomes really important as we get older. Our tissues just want to tighten up, and especially anything you had surgery on. So most people, I think, have to do a little bit of maintenance even after their knee. So give it a little bit of time. Like, you had your surgery 6 months ago, it's good, but that scar tissue is still going to want to reform a little bit for probably up to a year.
Okay.
And just in general, sitting, we tend to get tight in our hip flexors and our quads, our hamstrings. So there's some muscles just from living on the planet that tend to tighten. So just stretching in general is a really good thing to do.
We're getting down near the end of this, and I can't leave without asking you one question. I have watched interviews on television. I've heard them on the radio. I've read them, or I read them in newspapers and the internet. I cannot find one medical person, medically related, that isn't bringing up AI. I never knew what AI was till, I don't know, maybe a year and a half ago, and now it seems I can't draw a breath without somebody talking about it. Is AI a factor or becoming a factor in the physical therapy world?
I think it's not a huge factor yet, but I think it's going to be, and I'm not sure our profession is ready for it. I don't know if any of the world is ready for it, but when you look at this, I'm sure we could come up with a goggle that we could put on your face. You have vertigo, we ship it out, you get it that day, it rolls you around, it tells you exactly how to turn your head to get these fixed. I think that same for post-op protocols, where you would have do your exercise in front of a camera and getting immediate feedback. Okay, you don't have that lined up, shift your hips.
Yeah.
So I think it's going to be a big player in physical therapy.
Well, you made a comment earlier about gathering information for results and lining them up. What results did this give us when we did this, and this?
Right.
If through AI you can gather that information from every physical therapist around the world in a period of 3 to 5 years, you're going to have a ton of information, a ton of results. If the data lines up with the protocols that were in place to do these things, that's got to be helpful.
Oh, yeah.
It just can't help but increase your knowledge.
Right. I think the studies show, we discover something, it takes we know, okay, this is a really improvement in healthcare. I think it takes about 10 years for it to really be widely implemented.
Really?
And that is, so unacceptable. But, we started doing that Botox so long ago. Now it's getting more and more used for headaches, for example. But how long does it take from that early research we did 25 years ago to get widely used? It's a long time because everyone's busy. It's hard to keep up with the data. So, I think AI is going to be tremendous help. Like, what is the best thing for you with this problem?
Well, you can factor in the weight, the height, the activity level. There's so many factors. Again, that would go back to the protocol they're going to use to gather the information. But it seems to me it could be. If it seems to me it can be done, I'm pretty sure it can be done.
I think
I'm
so.
not the brightest bulb in the hallway.
Yeah, we don't know exactly how long you should hold a stretch after a total knee, but
that kind of thing.
Should you hold it 30 seconds or 2 minutes? It's gonna be very exciting to see all this come.
Are you incorporating it in any part of your life that relates to your business right now? Do you have a website that's a go-to or something?
Yeah, we probably need to do better. Not really. We've not done great with that yet, I would say.
Okay.
But I think a lot of practices were probably way ahead of us on that, where you could say, I'll tell them, okay, use this YouTube video to follow. This is what you have. But just always, not having people hurt themselves and make sure, a lot of our patients are elderly. And, so if the family members come, for example, to help like an elderly person kind of know how to do this technique. I had someone yesterday, they brought their daughter because it's kind of an ear that has a lot of crystals jammed in. Mm-hmm. So now I got the daughter to help me. And so
how do you know those crystals are jammed in? What are you?
So
are you seeing an image or?
So we're gonna put your goggles on your eyes.
Okay.
Okay, and then we're gonna watch your eye on the screen. So if it's this canal has crystals jammed, I'm gonna lay your head backwards, and you're gonna see your eye get a nystagmus gonna flick. And if they're jammed, the flicking doesn't stop. If they're floating free, there'll be a little delay.
You're going to be able to visualize that.
Oh yeah, we do this nonstop. And then, okay, so this person has a crystal jammed in this canal. So, it's often in the elderly, so now they have to go home and throw themselves around or break that loose.
Wow.
So having family help really makes a big difference.
And the balance issues that you deal with at your facility, you have some safety protocol, don't you, to hold them? I mean, if I've already got balance issues and you tell me to close my eyes, tilt my head back, and stand on one foot, I'm likely going to fall down.
Yeah.
How do you, am I in a walker situation, or what are you doing?
Well, the University of Dayton came up. This is another really cool thing I think that we're doing. It's called the slip trainer.
Okay.
So you put this person on this platform that moves, and then you put them in a harness and hold them up.
Okay.
Okay, and then we move the slip trainer to stimulate your balance system. And the research out of Dayton is showing like a half-hour visit decreases your fall risk for about 6 months. Just one visit. So you know how when you fall, you kind of get that startle?
Yep.
That's actually good because it wakes your system up. So that's what we're basically doing with this slip trainer. So
Just trying to keep it activated.
yeah,
keep
you're
it alert,
activating the system.
alert
So
all the time.
you could easily see that becoming just a part of aging. So
Yeah.
falls obviously are devastating. So we've been using the slip trainer for about 5 years now.
And will that awareness stay with you, or do you have to continually do it to
retrain
keep it
Yeah.
to keep it alert all the time?
Yeah, Cleveland State actually is just starting up. We want to do a study on this to see exactly what we need to do. So we're kind of in the early innings on doing research on this thing with Cleveland State.
That's really interesting.
Yeah.
We can't leave without talking about health insurance, which you and I discussed more than once.
Yeah.
They still have you as a physical therapy as a specialist. My son-in-law needed to see a physical therapist, and his copay was $90. I don't see any specialist that charges me $90. What's going on?
So Ohio just passed this law this year that physical therapists no longer have to be perceived as a regular practitioner, not as a specialist.
So it got passed in 2025.
Yes,
Go
but I
ahead.
guess my understanding is it takes a while for all this, the contracts or something. I don't understand the details, but by next year, my understanding is that they won't be doing that anymore.
So my copay may be back to $30, $35
That's like a family doctor's
Correct.
copay, which that's a rare win in politics for us. I think in healthcare.
Well, how long have you been working on it? I mean, how long has this been going
They've been
on?
fighting this for a long time.
So-
when we first opened, the average copay was probably $5.
Right.
Which honestly I didn't like because you want people vested in their therapy. So too low of a copay, people aren't as good about their home programs. Having skin in the game is a good thing, but we don't want to make it prohibitive. So a $90 copay, very
It can
few
be
people
prohibitive for people today,
very brutal.
Yeah.
So I think you're going to see,
especially when you may want to see somebody, 2 or 3 times a month.
right.
Now you're sneaking up on gas money and cable TV and rent money, and that's
The healthcare system really is pretty broken still.
yeah. You talk about how complicated the body is. Try figuring out healthcare
That's way
payments
harder.
and yeah.
Way harder.
How do you guys handle that? You got a small family clinic. You and your wife own it and run it.
Yeah.
Who does your billing? Do you have some brainiac sitting in the back room that I've never met?
No, so we have a billing company. So
Okay.
there's about 10 clinics all went together, and this guy is off-site, which is the only way you can do it because there's no way you could make it work. I don't think having on-site billing, it's just too expensive.
And I know just enough about billing to be dangerous for medical billing, but everything is sent in by a code number,
Right.
which relates to the treatment, and the pay is set by that code number. I presume physical therapy is no different.
Right. Right.
So this off-site place, you're probably dealing with a handful of codes.
Right. Yeah. It's not that many. So we send the codes, and then they send them. Yeah. We used to do it on-site, and
I can't imagine.
yeah, it was a
I
disaster.
mean, more staff than it would take to run the clinic.
Well, the phone just never stopped ringing with questions, and this
Yeah.
guy, that's all he does. So he understands at a level that one person can't.
So if I have a snafu in my billing, you're going to refer me to him to figure out what happened.
Right,
Got
and
it.
that's worked really well for us.
Let's talk about one other thing. In my time going to your facility, I see a lot of students. What's up with that? Where do they come from? How do you get them?
Yeah,
How do you
so-
treat them?
Hopefully we
Do you
treat them
hire
well.
them? Do you hire them when they're done?
We hire the good ones. Hopefully.
Okay, there you go.
So yeah, I think that's a really important part of our success. I have the experience, but they have the newest knowledge, and the best people in our field tends to be the professors. So they're getting it, the most up-to-date stuff from their professors, which are usually leaders in our field, and then they bring that to me, and that's really so important, I think, in terms of keeping up to date, because this field is going a million miles an hour, and there's never been a student I haven't learned a lot from.
That's interesting.
Yeah, never, because they all have things that maybe they've gone through themselves, or they've, most students end up specializing in something, doing a paper, so they're going to have super big knowledge on that area. So we take them from, I don't know, probably 12 schools. And some of the schools we worked with more often, they kind of know, what's a good fit. Our clinic is, we kind of all work as a team. So
You do?
So you got to have that flexible personality. So, PJ's our foot guy. So you come in, I think it's your back. It turns out it's actually your foot. Then PJ's going to swing over and take a look, and I'm going to help him. So it is pretty fluid. So we need students that can kind of float around a little bit.
Yeah, I've never met a wallflower up there. I mean, you guys are all personable, and they're personable, and it looks like you've handpicked them.
Yeah, we have a really good staff. I'm really lucky to have them, and I think almost everybody has been our student. So when there's a good one, I usually try to pluck them.
Sure. Vince, this has been fascinating. I can't believe an hour is gone already.
That was quick.
But thank you very much for coming in. And if you need physical therapy, Wadsworth Family Physical Therapy up at the North End. Thank you all for watching Tell Ted. Till next time.
You are watching WCTV, Wadsworth Community Television.